your question. Once you have read this, tell me one more slide.
Okay.
Yes, next.
Okay.
Right. If you have read and understood, kindly begin your station.
Okay. Hello. Good evening. I am Dr. Mohammed, one of the surgical doctor registrar working for Mr. Mann in X Hospital. I am calling to speak Mr. Sunday as cardiothoracic consult on call to ask him to accept a referral of a polytrauma patient with wide mediastinum. Could I check that I am speaking to Mr. Sunday?
Good evening. Yes, you may proceed.
Okay, nice to speak, Dr. Sunday. Please, ma'am, move the slide.
Yes, first one. Yes, please.
23 years old male admitted to the hospital as a post RTA. He complained of right side chest pain. On examination, Glasgow Coma scale 14 and heart rate 120, blood pressure 100 on 80 with normal temperature. The investigation on the hemoglobin at urine and electrolyte and liver function test with the normal CRB minimal reset and ABG with metabolic acidosis on examination. Left thigh swallowing. Ma'am, move this
Yes.
slide. And done chest X-ray wide mediastinum with bilateral pleural effusion and abdominal X-ray suet shadow and dilated small bowel lobe and left femur X-ray shaft fracture and CT not available in the 3 days. I started by 4 liter of the crystalloid and we cross-matched 6 units of the blood. I am calling to advise about your case and the update of management.
Okay, doctor. Doctor, how would you manage the C-spine in a trauma case
C-spine.
like this?
Yes, I will support using hard collar and sandbag and the tape.
Okay, so what about the leg? You said the leg is swollen and there's possibility of fracture. How will you manage the leg?
The managed the leg traction with the Thomas splint.
Okay, then how will you manage the patient? Your approach to the patient in general.
the manage the patient according to the ATLS protocol. Start the fluid resuscitation. Would monitor the patient with blood pressure, urine output, and pulse, and monitoring capillary refilling time. If not respond, can be 1 liter of the crystal light. If not respond, can be blood transfusion.
Okay. Then, why do you think the patient is having a metabolic acidosis?
Okay, because the patient has a closed fracture of the femur and the compartment syndrome as the possible cause, and maybe due to patient hemorrhagic shock and the patient now case of diabetes, maybe diabetic ketoacidosis.
Okay. Then you said something about the boost on the abdomen and the absence of sugar shadow. So how will you manage this?
Yes, that switch shadow denote the presence of the intra-abdominal injury like splenic injury, maybe need require exploratory laparotomy.
Okay. So is that urgent? And can that be done at your hospital before transfer?
Yes, this is urgent.
Okay. And what do you think? Do you think the operation can be done at your hospital before the transfer?
Yeah, maybe need the whole trauma team. I will come with our anesthesia college or ITU college.
Hello.
Hello.
Yeah. Okay. Then again, what do you think is happened with the chest X-ray? What do you think is causing the widening the mediastinum?
Yeah, I think the patient chest X-ray wide mediastinum, maybe I think aortic dissection and aortic aneurysm and pneumo or hemothorax.
Okay. Then, will you be coming with the patient? Who will be coming? Who will accompany the patient?
Yeah, requirement to update about the management of in this case.
Okay. I ask who will accompany patient
Who
during the
will come
transfer?
with the patient?
What?
Who will accompany the patient? Who will come
What?
with the patient when you're transferring?
Yeah, the whole trauma team. I will come with one of our anesthesia colleague or ITU college and myself.
Okay. So is the patient stable now?
Is
Okay.
patient stable?
Is it
Yes. Yes. Start fluid resuscitation and prepare patient with the blood transfusion, and now the patient is stable.
okay? So has any CT scan be done, or do you think the patient needs a CT scan before the transfer?
The CT scan not available. Next 3 days it will surface.
Okay. So is there any chest tube in place? And what is the output, if there's any?
Yes. What are the
What?
outputs?
What?
Hello.
Patient's output? I haven't written.
Yeah.
So I ask, what's the patient output?
Can you tell how much urine output is? It's not given.
Yeah. The urine output not given in this in this notes. I will check again.
Yes.
Okay. Then do you have any other thing you would like to ask or say?
Why the blood
Yeah. Monitor
pressure?
urine output with the
Hello. Continue, please.
yeah. Start with the IV fluid with monitor and add inotrope if the persistent low.
Okay. Yeah. So you can send the patient over.
And then in this one, you
Okay,
have to
doctor.
you have to make him summarize your instructions.
Yeah. So can you
Okay.
just summarize my instructions?
Okay. 23 years old male, post RTA admitted to the hospital, complaint of right side chest pain, and on examination Glasgow Coma scale 14, and the heart rate 120, blood pressure 80 on 100 on 80, with normal temperature, and hemoglobin dropped, and another investigation urine and electrolyte and liver function normal, and the EBG metabolic acidosis on examination left eye swallowing, and abdominal X-ray absent Swiss shadow, and chest X-ray done wide mediastinum and bilateral pleural effusion, and the X-ray of the lower limb shaft fracture, start fluid resuscitation with the crystal light with blood blood transfusion at both chest tube on the right side.
Yes, and then you have to summarize, like he asked you to monitor the output, and then tell him.
Okay.
Yes, good.
Yeah, would monitor with blood pressure. The patient would monitor the patient with blood pressure, urine output, and capillary fill time, and the mental status.
Yes, good.
If the stable, send the patient.
Yes, good. Thank you.
Thank you.
Yes, feedback,
Thank you,
Dr.
ma'am. Thank
Sande.
you, Dr.
Thank you
Sandaya.
so much.
Yeah, my feedback, Dr. Mohammed, is improving
Yes,
every
very
day.
much. Yes,
Yeah, and of course, you still need to improve on the communication skills.
yeah,
But then, when I asked whether the patient was stable, he said the patient is stable, but from the note, the patient is not stable.
no. And then you
So,
have to ask him
to follow,
that how will you make the blood pressure stable, and why you cannot raise the blood
yeah,
pressure all of a sudden.
exactly. But he said the patient is stable,
Yeah,
so
Yeah,
I couldn't ask how to stabilize the patient.
yeah,
So that was going to be the next question.
yeah,
So, then any information that you don't have, it's better you say, "Oh, I'm afraid I don't have information that I would like to check." Not if
yes,
it's not the thing in the notes, because the scenario might not be based on the notes.
yes,
Yeah.
good.
So just some little
Yeah,
things that I work on based on the scenario given.
scenario given. Yes, good. Thank you. Thank you, both of you. Here is the question. Right, if you have read and understood, kindly begin your history taking.
Hello, I'm good evening. I'm Dr. Sunday, one of the surgical doctor. I'll be the one attending to you today. Can I just confirm your name and age, please?
My name is John, and I'm 26-year-old.
Linda Roberts, 35 years
Sorry,
old.
my name is Linda, and I'm 35.
Nice to meet you, Linda. So today I'll be asking you a couple of questions regarding your. Is that okay with you?
Sorry.
I said I'll be asking you a couple of questions. Is that okay with you?
Yeah, sure.
Okay. So what seems to be the problem?
I'm having a kind of abdominal pain at the upper abdominal since almost like on and off for last 6 months, and it's keep on radiating to my back, and sometimes it's associated with a lot of vomiting, and my stool sticks when I try to flush it off, and I also have since a bit of the weight loss since 6 months.
Oh, I'm sorry to hear this. So talking about this pain, so you said it moved to the back, right? And does it move
Yes.
to any other place?
Sorry.
Does it move to any other? Does it move to any other place apart from the back?
Yeah,
Does
it moved from
radiate?
my upper abdomen to the back.
Okay, so how? When did you first notice this pain?
I'm sorry.
When did you first notice this pain?
I noticed it back 6 months back, and when I usually go to the hospital, they give me certain medication, it relieves, and then I come back home. Then again had the same episode, and I had to rush back to the hospital. And now the episode has been so frequent, and the pain does not relieve very oftenly.
Okay, so talking about the episode, does it just come and goes, or was it just constant? And is it does it include? Continue, please.
Your voice is getting interrupted.
No. Continue. You're saying something.
The pain is kind of a cyclic. It goes and it started in increase in intensity, then it goes off by medication, but now it has been so persistent that it does not goes off by any kind of medication.
Okay. So and this pain, how is the intensity? Has it increased over time, or reduced, or stay the same? What do you think?
It has been increased. It has been increased.
Okay. So and if you have to rate the pain on the scale of 1 to 10, so 10 being the worst imaginable pain, how would you rate this pain right now?
I'll scale my pain till 8.
So sorry to hear that. So would you like me to give you any medical analgesia to suppress the pain?
Yes, please.
Okay, so I will order the nurse to get that to you. Okay, so when you feel this pain, do you have any other symptoms? Do you feel sick, like vomiting or nausea?
Yes, I have vomiting. Whenever I eat something, or even after it has been long that I ate it, that I start vomiting it out. It's very hard for me to digest and take anything inside.
Okay, so do you notice any chest pain or heartburn?
No, I did not notice any kind of chest pain, but yes, I have noticed the upper back and lower back pain.
Okay, then how about your appetite? Do you notice
My
any
appetite
changes
has
in your
been,
appetite?
yeah, it has been pretty much decreased. I don't like eating anything at all.
Oh, I'm so sorry. That must be hard. So, have you lost any weight at all recently?
Yeah, I have lost a bit of the weight. I was initially around like 80 or something, and now I'm around like 65 kg.
Okay, I see. Then, do you expect any kind of fever when you have this pain?
I used to have a very low grade fever in the night. It's been there for like since 3 months.
Okay. So, do you notice any changes in your bowel movement, bowel habits, for the past 6 months?
I feel like that sometimes I have loose stools, and sometimes I have a normal bowel habit. I find it very hard to flush out whatever I defecate.
Okay, I see. So, and how do you feel in general? Do you feel tired, exhausted?
Yeah, I feel it the same way that you say, like tired, exhausted all the time without even doing anything. I really wanted to lay on my bed all the time. Don't feel like doing anything and my normal chores.
I see. So, I would like to ask you about your past medical history. So,
Yeah, sure.
is there anything you've been treated for before in the past, or anything that you see your GP for?
Sorry, what did you ask?
I'm asking, is there any thing you go to the hospital to treat in the past, or is there any disease that you treat with your GP that I should know about?
No, I have been recently on and off went to the hospital and the nearby GP for this pain that I have described you, which I had since last 6 months, for which I have been prescribed numerous of the painkillers. Sometimes the pain goes off and sometimes it stays.
Okay, so you said earlier that you were taking some medication. Can you tell me what was the name of the medication and the dose of the medication, if you can recall?
I have been prescribed the paracetamol around 1 gram 4 times a day, and some doctors have prescribed me NSAIDs, which have been taken
Morphine.
for 2 times a day. And sometimes I have been given as a week opioids and the morphine to be taken twice or thrice a day.
30 milligrams.
Okay. So have you had any surgery in the past?
Sorry, have
Any
you?
surgery in the
Have
past?
you had any surgery?
Yeah, okay. No. I just had the surgery for the gallstones almost 6 years back.
Okay. So is there anybody in your family who must have had similar problem that you know of?
No, no such history relevant to my medical condition, but despite that, my family has a history of the blood pressures and all that.
Okay. So I would like to ask you a couple of questions regarding your social life. So
Yeah, sure.
what do you do for a living? What do you do for a living?
I am a teacher by profession.
Okay. So who lives with you at home?
Sorry.
Who lives at
Who lives with you at home?
Okay, I live with my husband and my 4 kids.
Okay. So do you smoke and drink?
Yeah, I drink like almost daily a half a bottle of wine or a vodka.
Okay, I see. So I understand that a lot is going on and you're in severe pain. So can you just tell me, in your own words, what you think might have caused this your problem?
I think it has to do with my sugar that I have, the diabetes, the diabetic that I am, and since past days I'm drinking a lot. It could be the reason why I'm having such kind of the weird sign and symptoms related to my abdomen. I really want it to be sorted out.
Okay. So is there anything you are concerned about, or how has this thing affected your daily activity?
The thing is, I'm pretty much concerned, like whatever I am having right now, is it something that can be cured or not?
Okay. So and what are you expecting from me to do
I
for
want
you?
you to know, I really want the reason why I came all the way down here, that I've been to multiple doctor, but I couldn't find the reason why I'm having this so frequently. So I really wanted to have my diagnosis.
Okay. So don't worry. We'll get to the root of this together. So I'll have to go and discuss with my senior, and I'll get back to you as soon as possible.
Okay.
Thank you for your time.
Thank you.
So,
Thank you.
I would like to summarize my case now. Today,
Yes.
I took a history of a 35-year-old lady
Yes.
who is who drinks a lot every day and vodka, and she has been having abdominal pain for the past 6 months.
Yes.
So initially, and the intensity has increased over the time, and now the pain, according to her, was about 8/10, which is very severe, and it reduced to the back, and the pain is located around the epigastrium and related to the back. And she also complained about vomiting, and also complained that her stool sticks to the toilet when going to toilet. So based on my findings, so my most differential diagnosis will be chronic pancreatitis.
Yes.
So because she also took some medication for the pain that worked initially, but now they don't have any effect, and the medication will be paracetamol 1 gram and morphine about
Yes.
20 milligrams. So and also I would like to also exclude other causes like maybe cholecystitis or acute pancreatitis that's superimposed over chronic pancreatitis. Then maybe gastric ulcer due to the
Yes.
epigastric pain and
So what investigations are you going to carry out for this patient?
So after this, I would like to do proper abdominal examination for the patient.
Yes.
Then I would like to do baseline blood work to check for the full blood counts, liver electrolytes, liver function test to rule out the obstruction for the bile duct. Then also
Yes.
I would like to check for the amylase level and the lipase level. The lipase level is more important. Then do the CT scan of the abdomen to rule out the pancreatitis and also ultrasound before CT scan.
Okay.
Then if need be,
Yes. What is the treatment options that you are going to offer her?
So First of all, because patient have been taking, we have to address pain medication
Yes.
analgesia intravenously to solve the pain. Then, of course, we have to do scoring system for pancreatitis to know the severity. Then we have to stabilize the patient, and also then
Yes.
we can now do hormone replacement for chronic pancreatitis, and after that, yeah, those are the major treatments. Then, if need be, we can do ERCP if it is caused by obstruction of the center of OD.
Do you think patients' habit of taking 30 milligram of morphine every day, does that need to be addressed? Is it like worrying for you?
Yeah, it's worrisome that she's taking that lot of morphine because of dependency. So I would like to have to consult with a or a specialist for cognitive behavioral therapy.
Yeah. How much should be the normal dose?
Yeah, so morphine orally is about 15 milligrams. So, but it can be up to 30 milligrams depending on the tolerance of the patient.
Yes. How frequently can you give 30 milligrams?
Oh, so it should be once 30 milligrams per day.
Every 4 hours as needed.
Yes.
15 to 30 milligrams per 4 hours. Okay. Very good. Thank you. Still had. Okay. Right. Thank you so much. So for me, yes, everything was good. You covered everything. Time is the factor. You took 3 minutes extra.
Yeah, I was expecting that to be more direct with some answer, like no family history, but she was explaining that I can stop the patient. I cannot interrupt, so I left her. I was hoping that some answer that I was yes or no answer from it, but it's good. She's a very good actor.
Yeah, very good. Yes.
Okay.
And here is your question. Right. If you have read and understood, can you please identify the structures?
Yes.
Here. Yes, please.
Okay.
If you can identify number 9, please.
Okay.
In picture A.
In picture A, number 9 is the lateral tubercle.
Yes, of what?
Lateral tubercle of the tarsal bone.
Talus.
Talus. I told you tarsal. Talus.
Yes, it's important to pronounce the because tarsal and talus.
No, I was thinking on talus, but I pronounce it tarsal. Yeah, it's my bad.
What is number 13, please?
Okay, 13 is the medial surface of the calcaneum.
Yes, and number 1, please.
The anterior, I think it's the anterior tubercle of the calcaneum.
Calcaneus.
Yeah.
Calcaneum. Okay. What is number 2?
Okay. Number 2 is, I guess, the cuboid bone.
Yes. Number 3, please.
The first metatarsal.
Very good. And number 4.
Where is number 4 here?
Yes, here.
Okay. Number 4 is the neck of
No.
No. Is it the head?
Yes.
Head, yeah. The head of talus.
Yes. Okay. What is number 15?
The navicular bone.
Yes. What type of bone is navicular bone? Is
What
there
type of
anything? Yes. Is there
bone?
anything special about it?
I don't know.
Okay. Can you please identify number 11? Have we done this?
Yes. So the 11 is the malleolar surface of the talus.
Okay. And number 10, please.
So the number 10 is the cuboid.
Which one?
I said okay, number
You
10.
said
I said
cuboid. Number
yes.
10 is not cuboid.
No.
See, you need to
Number
read.
10, it's not the cuboid. Number 10 in the picture below. Yeah, I got it wrong. So number 10 is the lateral cuneiform.
No, medial cuneiform. How
Yeah,
many
true.
cuneiform bones are there?
There are three. There is
Yes.
10, which is medial cuneiform. The 5 intermedialis cuneiform, intermediate cuneiform, and 6 is lateral cuneiform, and 2 is cuboid. Yeah, true.
Yes, okay. In picture B, can you identify what 19 is, please?
It's the tarsal sinus, isn't
What
it?
is the significance of tarsal sinus?
There is a passage of vascular nervous structure which can be compressed and causing neurological, I think,
What should be the management of neuralgia?
I think in some of the situation they need to make bigger space by maybe doing osteotomy.
What is 20 over here, please?
It's the base of the 5th metatarsal bone.
Tuberosity of
Tuberosity of the base of metatarsal bone, yeah,
yes.
of 5th.
What is 8, please?
So now the 8 is lateral process of the calcaneus bone.
Okay. Yes, please. What is 2 over here, please?
Okay, 2 is the 2 is the cuboid.
Yes. Okay. Can you please identify 9 over here, please?
Okay.
This point.
So 9 is the lateral tubercle of the talus.
Yes. Okay. What is 5, please?
So then 5 is intermediate cuneiform bone.
Okay. Can you tell me how many arches are there in the foot?
Okay, there are 3 arches in the foot.
Yes.
There is medial longitudinal arch.
Yes.
There is the lateral longitudinal arch and transverse arch.
What are the components of each of these arches?
Okay, so in the medial longitudinal arch for the bones, that is coming from calcaneum, talus, navicular bone. So and the 3 cuneiform and the 3 metatarsal bone, the 3 medial metatarsal bone. And for the ligament, so we have interosseous membrane, the long interosseous ligament, the plantar aponeurosis, and okay, and the deltoid and the spring ligament in the medial. So for the muscle, so we have the tibialis anterior and posterior, the short muscle of the big toe. So, and
No,
we have the
you
flexor
are. Yes, you have to read these components of each arch properly. You're mixing.
Really? Because this is from
yes.
my notes.
Yes. Are you reading notes? And
No,
telling
I'm
me?
not reading, but from
Yes,
the
but
notes
then
I read.
you're mixing because the ligaments and muscles are not like this. Yes. Okay. Can you tell me what are the movements which are present at the foot?
Okay, for the movement of the foot, we have the dorsiflexion, we have the plantar flexion of the foot, we have eversion and inversion.
Okay. What are the structures which stabilizes the foot?
We have the ligament that stabilize the foot.
Yes.
In the medial.
Yes, and
the articulation, which means between bones.
Yes.
Yeah.
Okay. Can you tell me in which position, on stance or sting, the foot is more stable?
So it's more stable on dorsiflexion.
Okay. So can you please tell me what are the muscles of walking and climbing
Okay.
the stairs?
Okay. So walking and climbing the stairs. So we need to involve the muscle of the anterior, I think, compartment. I mean, I don't know about this question, to be
Okay,
honest.
can you please tell me what is the anatomy of the deltoid ligament?
Anatomy. So
Yes, please.
where it is attached, you mean?
Whatever you understand, anatomy of the deltoid ligament.
So I know that it's a ligament which is involved in the medial side of the foot, medial part of the foot, which is inserted on superiorly to the medial malleolus, and inferiorly it will be attached to the spring ligament. It will be attached to navicular tuberosity. It will be attached to the body and neck of the talus, and it will be attached to the systenticicular tali of the calcaneum bone.
What are the movements that you find at the subtalar joint?
So in the subtalar joint, the movements are eversion and inversion.
Good. Okay, what are the muscles which are responsible for these movements?
So we have peroneus longus and peroneus brevis. And as well, contribution of peroneus tertius as well, but less.
For which movement are you telling me about, please?
For eversion. And inversion, for eversion is peroneus longus, peroneus brevis. For inversion, it's tibialis anterior and tibialis posterior.
Okay. What type of joint is subtalar joint, please?
It is a synovial ball and socket joint.
Yes.
Yeah.
Okay. What do you understand by the term mid-tarsal joint of Chopard? What does
So
it mean?
so the mid-tarsal joint of Chopard will involve two joints. So it will involve the calcaneocuboid joint,
Yes.
and the navicular talar joint.
All right, good. Thank you so much. Thank you. Well, has